that we want to get to you is to get these ideas of body reading across in a very practical way. But if I start in a more formal way, the 5 stages of a structural body reading would be good to have. The first one is the one we're going to spend the most time on, which is where is the skeleton in space? So the first question that we ask, the first task that we do is, what is the skeletal geometry? We're going to answer that question in terms of the skeleton can tilt off the vertical line or tilt relative to a horizontal line. And so that means you could have a left tilt or a right tilt or an anterior tilt or a posterior tilt. And then we'll go through the rest of this in a minute. The first stage, however, is to describe the relationships in the skeleton as the person stands there in posture. We're going to use it in posture, but this could be true in any given, you can take any photograph and define it in terms of what's tilted, what's bent, what's rotated, what's shifted. And that is the first stage. You want to know where is the skeleton in space. Stage number 2 is what is the soft tissue that is creating or maintaining that pattern. So when you say, okay, if there is a left tilt in the rib cage relative to the pelvis, then what do I do? Well, maybe the lateral abdominal obliques or the quadratus lumborum or the psoas or something over here is holding that rib cage over into the left hip. So step 1, what's happening to the skeleton? Step 2, what soft tissue could I possibly work on to open that up? Then stage 3 is take all of those things, by which I mean the skeletal position and the soft tissue that I think is holding it, and create a story. You don't have to do this with every little thing, but when a client comes in, you want to put together a story that explains to yourself as best you can all of the elements or many of the elements that you see in somebody's structure. In other words, we're going to show how posteriorly shifted knees, hyperextended knees, are going to shove the lumbar spine forward. So you see knees going back, lumbar spine going forward. In lots of cases, these two are related events. And if you are going to sort one, you'd better also sort the other if you expect it to stay in its new position. So we're going to put together a story. Oh, she has a lumbar lordosis and it's connected with the hyperextended knees. So we put together the best story that we can based on history, based on what we know of the person, based on our experience. And then stage 4 is develop a strategy. Now that strategy might be the next move I'm going to make. It might be a strategy for the whole session, or it might be a strategy for your whole time of working with this person. The kind of work that we do in the school that I run has a 12-session series. So at the beginning we strategize for that whole 12 sessions, but you may not be thinking that way in terms of your clients. You may be strategizing for the next minute. It doesn't matter, the process is the same. Where's the skeleton? What's the soft tissue that's holding it? What's the story that makes the most sense to me? And then boom, what's my strategy? You figure out a strategy for what you're going to do next. You go and do that strategy, and stage 5 is the stage that comes into all scientific or iterative endeavors, which is look and see what happened. If it worked, if the tilt in the ribcage, just for example, has come back, then your strategy was successful and you can go on to the next thing. Start back at step 1. If your strategy was not successful, you have to go back somewhere and say, oh, I didn't see the skeleton right, I didn't analyze the soft tissue right, my strategy wasn't right. So you go back to one of those stages, reform a different strategy, look again and see what you're going to do. It is a process that goes around and around, and it goes on different time scales depending on what kind of strategy that you're looking at. But 5 stages, reviewing again, are what is the skeletal geometry, what is the soft tissue that could be holding that, what is a story that fits most or all of what I see in the person's whole pattern, what is then going to be my strategy, and did the strategy work? If so, go on. If not, go back. Those are the 5 stages. Mostly we're going to be focusing on where is the skeleton in space, and we need the 4 terms for that right away. And then what soft tissue will be holding that. That's the one we're going to focus on. We'll be going into stories and strategies a little bit, especially with those people with whom we do a whole body reading in the course of these webinars. Let's go look at that terminology that we need to practice for understanding the skeletal geometry. Okay, for stage 1 of the body reading, we're we're going to need, and we're going to be constantly using, and I highly recommend that you put into practice to understand 4 terms. They're easily I really like this language. They're easily understood terms. They have an intuitive meaning to the client. They will bear the weight of a very detailed discussion about the shoulder or the individual segments of the spine or the bones of the feet. And yet you can create a quick sketch that will be understandable. We use this language all through our school. We have been for years. It works really well. So we're commending it to you. And it also, people write me or email me or talk to me saying, I have somebody at home with a left tilt of the ribcage and a right tilt of the head, and I want to know what to do. They can give me a quick sketch of what the structure looks like in just a few words. So I highly recommend that you get on top of the language that we're about to use. 4 terms really can describe any position. The first term is, the 4 terms are tilt, bend, rotate, and shift. Tilt, bend, rotate, and shift. And let's go through those. And I highly recommend, as I'm doing this, you can watch me on the video screen if you want to, but if you are in the privacy of your own home and nobody's going to think you're looking stupid, get up and do it with me. Because if you have a sense of this in your body, it will be much easier to see it in other people's bodies. You just sit there and watch, or if you already know and understand the terms, that's great. You can skip this part and go to the next. The term tilt, the first one that we'll be using, one that we've used very commonly, means that a body part is tilted off the vertical line or off the horizontal line relative to another part. Okay, if you want to do it relative to the floor, okay, you can say so. Or if you want to do it relative to a gravity line, okay, you can say so. But what I'd like you to notice is this is a left tilt of the shoulder girdle relative to the floor. But there aren't a lot of muscles connecting the shoulder girdle to the floor. It is also a left tilt of the shoulder girdle relative to the pelvis. See, my pelvis is more or less level. The shoulder girdle is tilted to the left, so my shoulder girdle is tilted left. By the way, it's always the client's left, right, anterior, and posterior. This is client-centered therapy. We will use the client's left and right. So left tilt means that the top of the structure that we're thinking about, the shoulder girdle, has gone off to the left. Relative to what? Relative to the floor? Yep. Relative to the pelvis? Yep. Relative to the rib cage? Nope. Because the way that I did this, my shoulders and my head and my rib cage all went to the left. So yes, it's a left tilt of the shoulder relative to the floor or the pelvis, but is it a left tilt of the shoulder relative to the rib cage? No. The shoulder relative to the rib cage is neutral. In other words, with this problem, I don't want to go working a whole bunch of things that go between the rib cage and the shoulder. There's lots and lots of muscles holding the shoulder to the rib cage. Because those aren't the ones that are in trouble, even if he's complaining about the rhomboids over on this side, which is what's beginning to hurt with me when I stand here for long enough. Because that isn't where the problem is. Down here, when we get to the soft tissue part of this, to undo this tilt is going to happen between the rib cage and the pelvis. So we need to understand what structure is tilting, what structure is doing any of these things, relative to which other structure, because that will lead us to the precise soft tissue kinds of strategies that make your work more efficient and longer lasting. So, a left tilt here, however, there is a left tilt of the shoulder girdle relative to the rib cage. My rib cage is still more or less steady, and my shoulder girdle has a left tilt on top of that. Okay, now I'm thinking about, because the tilt is relative to the rib cage, now I'm thinking about the muscles that hold the shoulder to the rib cage, the myofascial units to be precise. Anyway, I'm thinking about the tissue that holds the shoulder to the rib cage, because that is a problem, an aberration, a compensation between the rib cage and the shoulders, whereas this is not. This is problem, aberration, compensation between the rib cage and the pelvis. Ergo, I'm led to the soft tissues in between the two. Okay? So, remember we name a tilt. I don't think I've said this yet. We name a tilt for what happens to the top of the structure. So if this is the shoulder girdle, the top of the shoulder girdle is going to the left. Do you see that? The top of the shoulder girdle is going to the left, so we call it a left tilt. Right tilt, anterior tilt, posterior tilt. What happens to the top of the structure? So show me a right tilt of the ribcage relative to the pelvis. Okay, here we go. I didn't tell you what to do with the shoulders and the head, so you really had two choices of what to do with that. Can't avoid this. This is a right tilt of the ribcage relative to the pelvis. But then the question is, do the shoulders and the head come back on top of that? Or do the shoulders and the head go with the ribcage? That would be another description. Right now, we're just talking about the relationship between the shoulder and the ribcage. Ribcage is right tilted relative to the pelvis. So the pelvis, if we look at it, we could get an anterior tilt. I know you physiotherapists are used to calling this an anterior rotation, but in this language we're going to keep consistent. Everything that where a structure is going off the vertical, we're going to call it a tilt. So anterior tilt, posterior tilt, somewhere in between is neutral. We can argue that over an adult beverage sometime, what is exactly neutral. But we all know what a severe anterior tilt looks like and what a severe posterior tilt looks like, and neutral's somewhere in the middle. Now, if we have an anterior tilt and a posterior tilt, we could also have a left tilt and a right tilt. If we can come down to the feet, I don't know if you can see the feet in this, but when we look at feet, what you would call a flat foot or a pronated foot or an everted foot, we're going to call a medially tilt foot because the tilt is happening in the foot and the top of the foot is going medial. A supinated foot, or somebody who is standing, let me just get this so you can see my feet better, on the outside edge of the foot, supinated foot, we're going to call that a laterally tilted foot. So everything left tilt, come on back up to the upper body here. So a left tilt of the head, a right tilt of the head. I think this is pretty straightforward. Tilts go off the vertical line, either anterior, left, right, or posterior, and it's always relative to something else. Okay, so now we're ready to go on to our second term, which is bend, and that's not going to take us very long because bend is just a series of tilts. We only use it in relationship to the spine, and I think we'll just use this little spine to make this demonstration easier to see. So if I have L5, this guy's got a dislocation here, just let me fix it. Okay, two of them help. If you look at the lumbar spine here coming out of the pelvis, if I have this spine take something like this, you could call this a series of tilts. You could say L4 is tilted on L5, and L3 is tilted on L4, and L2 is tilted on L3. But honestly, it's just easier and more convenient to say there is a what? A left bend in the lumbar spine, because the topmost vertebra is more to the left than the bottommost vertebra of the section that you're looking at, whatever section you name. And often that's going to be accompanied by a right bend somewhere else in the thorax. So we'll be looking at these bends. Understand bends never happen without rotations, I understand that, but we're going to separate them out for the purposes of working because of the strategy consideration. If you understand where the bends are, you know where to go for strategy. But if you look, we can have a left or a right bend of any. It could happen at one segment, or it could happen, more often does, at a series of segments. So I could have a left bend in the cervicals, a right bend in the thorax, and then a left bend in the lumbars. And this will actually work out pretty well for the person. Not great, but pretty well for the person involved. And we want to be able to understand those bends. So understand bend as a series of tilts to the left or the right, and that we're going to be able to read those. Now there is one piece here that you really gotta have. Imagine that I'm doing this. So I am hiking my hip up. What is the bend in my lumbar spine? So my right hip is higher. My thoracic spine, I hope, is more or less straight up and down in gravity. So what's got to be happening here? Well, there's a bend. Is that a right bend or a left bend? Well, if L5 is like this and L1 is like this, the bend is to the right because the topmost one is still to the right of the bottommost one. I hope that's not too confusing, but it is important because if you see this, If the pelvis is tilted, then the spine is very often like a tree growing out of the hill. It gets out of the hill and then it becomes heliotropic and it goes straight for the sky or towards the sun or away from the earth or whatever trees do. Spines do the same thing. If it's coming out of a tilted pelvis, then you're going to have this bend. What kind of bend is this in the spine? It's a left bend. How do I know? Because I'm sorry, don't do that, especially in a webinar. It's a right bend. Because if I took the pelvis and I put it like this, you would see the lumbar spine bending over to the right. The bend in the lumbars hasn't changed when I go from here to here. The relationship to gravity has changed, but the relationship between the thoracic spine and the pelvis has not changed. It's the same relationship. What we're talking about then is unbending the spine. That would be a change in relationship. That's what we're going to be trying to do with our body work, whether you're doing it through movement, through manual therapy, doesn't matter, but you need to be able to see that this is a right bend of the lumbars. Now, that's great for left and right, but we also have anterior and posterior bends also in the spine. And so the natural bend of the spine is to have a posterior curve or convex forward, concave back curve in the lumbars, a primary curve with convex back, concave forward in the thoracic spine, and then in the cervical spine, the same as the lumbar spine. It should be concave to the forward, concave back and convex forward, and what you call military spine that people sometimes get from whiplash would be cervical flexion. So that you don't want. Now, so when we're looking at bends front and back in the spine, anterior and posterior bends, then we expect to have a natural posterior bend in the lumbar spine, an anterior bend in the thoracic spine, and a posterior bend in the cervical spine. So when we notice these things, we're noticing excessive curves, an excessive lumbar curve in the lumbar spine, or what we call kyphosis, an excessive curve in the thoracic spine, or cervical hyperextension, an excessive curve, or indeed, as we were just talking about with the military spine, a lack of appropriate curve. So the curves themselves are supposed to be here. What we would be talking about with an anterior bend or a posterior bend in the whatever spine would be, we would be talking about the excess, which would be talking about something negative that's here, like an anterior bend of the cervical spine and whiplash, a posterior bend, which would be straight up and down, wouldn't it? You see this sometimes in older men who've lost their lumbar curve and are walking along like this because they don't have so much of a lumbar curve to work with anymore. So I think that takes care of the word bend. It's a series of tilts. Okay, so let's go on to our third term here. The term is rotation. You'll notice that tilt and bend dealt with things in the coronal or the sagittal plane. A left tilt, a right tilt, an anterior tilt, posterior tilt. We've got the sagittal and coronal plane covered by that, but we haven't got anything for what happens in the transverse or horizontal plane. And we're going to use the word rotation for that. Now, I know that these terms, one, they have commonly accepted meanings. Two, they're not in wide use in the way that we're using them as precise terms of position. And I just want to emphasize that even though these terms are very simple, that every client and every practitioner has an intuitive sense of what they mean, the reason we're doing the formal definitions is we've been using this language for 10, 12 years now in our school. It really, really works well. It will bear the weight of a very detailed discussion. I'm hoping it gets adopted universally. I would, wouldn't I? But I'm hoping it gets adopted universally because then osteopaths can talk to yoga teachers, can talk to physiotherapists, and we'll all be on the same page, rather than using words like genu varus and genu valgus, which, in my opinion, are just used to make a separation between the practitioner and the client. If somebody walks in to say they've got bow legs and you say, oh yes, you have genu varus, you've just told them in Latin that they have what they just told you in English. I don't think that that's a very useful process. What we need to know is the set of relationships and the soft tissues that are holding that so that we can change it, not name it. So our third term is rotation. Rotation is going to cover things that happen in the horizontal plane. So a medial rotation will be when the medial part of whatever you're talking about, I'm doing a medial rotation of my upper arm relative to the scapula. So what's happening? The upper arm is coming medially relative to the scapula. So medial rotation of the leg, lateral rotation of the leg. Now if we're talking about singular structures, the ones in the middle, if we look at the rib cage here, we're still going to name it for what happens to the front. So here is a left rotation. And again, I hope you're up practicing with me because it's just a lot easier to do this if you do the same thing along with me. So here is a left rotation of the rib cage relative to the pelvis. If I put a flashlight in my pubic bone or my navel, it would be aiming towards the camera, but if I put a flashlight in my sternum, it would be going off to our left. So that is a left rotation of the rib cage relative to the pelvis. You want to be really confusing? It is also a right rotation of the pelvis relative to the rib cage. However, we usually go from down to up because we're so concerned with postural compensation and gravity. So I'm usually going to relate the upper thing that I named to the lower thing that I named. A left rotation of the pelvis, a left rotation of the rib cage relative to the pelvis. But now try this. Take your rib cage into a left rotation. Take your pelvis into a right rotation. Now it's easy to see. The pelvis is right rotated relative to the rib cage. But now, if you look at the feet, we have the rib cage and its relationship to the feet. The rib cage to the feet is neutral. My rib cage is facing in this direction, straight towards you. The feet are facing straight towards you. The pelvis in the middle. So this is simple. We just come up, we take the pelvis, and we fix the rotation in the pelvis. In fact, we're going to be doing a series of webinars that take that into technique, but not here, the body reading webinars of how you undo the rotation between the pelvis and the feet. But right now, let's just say we have one, and you know how to undo it. So I'm going to undo the rotation between the pelvis and the feet, and everything's fine. Nope, everything isn't fine. You can't just undo the rotation between the pelvis and the feet and expect the rotation between the pelvis and the ribcage to undo itself, especially not if it's held deeply in the nervous system or, God forbid, in the fascial system, because then it's just not going to come out on its own willy-nilly. You're going to need to undo the rotation, the right rotation of the pelvis on the feet. You're going to have to undo this rotation, and for it to make sense for the client, which is the point of the object of the exercise, then you're going to have to undo the rotation between the pelvis and the ribcage. Then things are okay. But to understand, this is not one rotation, it's two rotations. It's a rotation between the ribcage and the pelvis, and between the pelvis and the feet. So you can have all kinds of rotations going on. Clearly, we'll see it, we're going to see it several times with the people that we're going to be analyzing. You will see a rotation in the body from the ankles to the shoulders, and then a counter rotation in the neck, because everybody wants their head and their feet to be going in the same direction. As I said before, I've been working for almost 40 years. I've never seen anybody with a straight spine. Everybody has maybe a small, but some kind of rotation in the thoracolumbar spine. So there has to be some kind of compensating rotation in the neck, usually, in the cervical spine, usually. Hope you got this idea of rotation. Oh, I know, I want to add just a couple things to this. So what is commonly called in physiotherapy land protraction of the shoulder is a term that is not sufficiently specific to us. So if you look at what is commonly called protraction of the shoulder, it's really a protraction of the whole shoulder complex, specifically the scapula, isn't it? So we want to be really precise about what we're saying. That involves a lateral shift, we'll talk about shift in a minute, and a medial rotation of the scapula. That's what I wanted to get to in terms of rotation. We said in rotation, it happens in the horizontal plane, and we're going to name it for what happens to the front of the structure. So if these are my two scapulae, in protraction, the medial part of the scapula, the front part of the scapula turns medially. The front part of the scapula turns medial. So there is a medial rotation of the scapula, there is a lateral shift of the scapula, stay tuned, and there may or may not be some anterior tilt of the scapula. The reason why protraction isn't good enough isn't precise enough for what we want to do. I love saying this because it gets the physiotherapists really mad because they think they're really precise, and they are really precise, but the word protraction is not precise. It is not precise at all. I need to know how far laterally did the shoulder go, how far medially rotated did the scapula go, and how anteriorly tilted or posteriorly tilted is it, because that's going to determine my soft tissue strategy. Protraction doesn't give me a strategy. Lateral shift, medial rotation, and anterior tilt does give me a strategy because it's that precise. If we can go down to the feet for a second, you get the same thing in rotation here. When you look at rotation in the feet, we can get really strange here. It does get really strange here because a hallux valgus, or a bunion, is actually, in our language, a lateral rotation of the big toe, which is really an awkward thing to say, but that's what it would be. Here would be a medial tilt of the feet, a lateral tilt of the feet, and sometimes you get very strange things where the forefoot is coming in, or the forefoot's coming out, or indeed the heels are tilting or rotating. Any of those things can happen around the feet. Mostly we're talking about a medial and lateral rotation of the legs, fairly straightforward. I think that does it about rotation without getting too bollocksed up in really great details. The simplest thing about rotation, name it for what happens to the front of the structure. I do want to say this one thing though, because we're going to be looking at spines, especially in the last webinar of this series, which is that if I have a right rotation of the rib cage, of course that right rotation, I've said rib cage, but it's going to involve the thoracic spine, right? The thoracic spine is also rotating to the right. No, these spinous processes are going over to the left. Yep, they are going over to the left. But what happened to the front of the structure? The front of the structure went right. So even though the spinous processes are going to the left, the sternum is going to the right, and we're simply going to name the rotation for what happens in the front. So you could say the front of the spine is going to the right. The back of the spine is, ergo, going to go to the left. Gets a little confusing on this right-left stuff when you get into it. I hope I haven't been too confusing. It's just simple, intuitive language, but it's worth going into the details because, as I say, you can use this language with great precision for all kinds of intersegmental and any kind of position you want to name that human beings can take in the universe. All right, so we got 3 terms in place that tell us about how the movement is happening at the joints. There's a medial rotation or a lateral rotation, a left rotation or a right rotation. There are tilts, and if you put tilts together, you can get bends. The last term that we need is of a different category. It talks about the center of gravity of one part relative to the center of gravity of another part. You could describe all this using tilts and bends and rotation, but the shift has proved really, really useful for us. Quick shorthand of talking about things, which is what is the center of gravity of the ribcage doing relative to the center of gravity of the pelvis? So, again, just like the tilts, we name them for what happened to the center of gravity of one part relative to the center of gravity of another part. So let's imagine that my ribcage is fairly neutral relative to my pelvis right now. It's over my pelvis. Now, if I do this, I have just done a left shift of the ribcage relative to the pelvis. This is really worthwhile being able to see what is the shift. Could be a left shift, could be a right shift, could be an anterior shift. That will be better this way, Tom. So it could be an anterior shift of the pelvis. Anterior shift of the ribcage relative to the pelvis. You don't see that so often, but I'll tell you, you see this one very often, which is an anterior. Whoa, what do I mean? Posterior shift of the ribcage relative to the pelvis. But I was jumping ahead of myself because I was going to say this could equally be said to be an anterior shift of the pelvis relative to the ribcage. And again, we get into the situation that we got into relative to the when we were talking about rotations. So if we can get all the way down to my feet on this one, so that we include the ribcage and the feet, you can see that I have an anterior shift of the pelvis relative to the feet, a posterior shift of the ribcage relative to the feet. So my ribcage is right over my feet, right? There's no problem there. I just have to take the pelvis and move it back. Well, that would be nice if you could do that, but here's what will happen if you do that. Zleek. You'll shift the pelvis back over the feet, but you haven't changed the relationship between the pelvis and the ribcage, and the person's going to fall off the back of their feet. Because look at the center of the ribcage here. So you may have done wonderful work on their legs to really center their pelvis over their feet, but they're not going to keep it because they feel like they're falling off the back of their legs. You have to consider all these relationships. So if you have a relationship like this, it's not just a matter of bringing the pelvis back over the feet. You also have to lift the rib cage, open this tissue up and back. We'll be talking about the specific strategies to do this. But if you understand that everything is in relationship to everything else, something like this is not a simple relationship. It's a set of relationships. One of those sets of relationships is between the pelvis and the feet. The pelvis is really shoved out in front of the feet. And if you want to think about that in terms of strategy, if you watch, what's happened is the superficial front line has been pulled down and the superficial back line has been pulled up. So the solution to this is up the front, down the back, and that will help you bring the pelvis over the feet. But that's no good if the person says, whoa, I would never stand this way, dude. So we have to do the tissue that's above that too to make that relationship make sense to the client. It's only going to work if it makes sense to the client. So we can have a left shift, a right shift, an anterior shift, or a posterior shift. Or, you get two more adjectives for this one. Conceivably, you could have a superior shift, like a superior shift of the shoulders, or an inferior shift, if you can imagine an inferior shift of the shoulders. This doesn't happen very often, so mostly it's left, right, anterior, or posterior shift, but you could have a superior or inferior shift in this. So, shift is talking about center of gravity. That makes it different from the positional descriptors, movement in a joint descriptors of tilt and bend and rotate. But I think you'll find shift really valuable. Once again, with shift we have this same kind of thing that we had with rotation, which is if my pelvis is here and my rib cage is here and my head is here, then my head is neutral, hope it is, can't see, that my head is neutral relative to my pelvis, but there's a right shift of the rib cage relative to the head, a right shift of the rib cage relative to the pelvis, and I can't just take the rib cage, let me see if I can do this, and just shove it back into place and have no consequences. If I do that, because of the shortness on one side or the other of my neck, this is what's going to happen. And you might have done wonderful work down here, but the person is going to say, my God, I'm looking through my eyes in the weirdest way, and they will put themselves back where they have their dominant eye on the center, or they have their eyes in the usual place. Because that's so important. So if I'm going to change the quadratus lumborum or the external obliques or whatever is holding the ribcage over here, I better also release the scalenes or whatever is holding this over here so that the head and the ribcage and the pelvis are in a line. So this is going to make your work more efficient because you're not going to do what you don't need to do. It's going to make it more effective because you're going to make sure that it melts into the body pattern as a whole, and therefore is something that the client can accept and just make part of their life, which is what you want. You don't want them saying, wow, you made a really big change. You want them saying, what headaches? I don't even remember that I had headaches. That's the kind of healing that I'd like to see, is where it just so integrates into their body that they don't have any more problems. I hope that you've got these terms. We're going to be using these terms like that, so you need to have this vocabulary down of tilt. A series of tilt is a bend. Things that happen in the horizontal plane are rotations, and changes of centers of gravity are shifts. We'll have visual aids to help you see this stuff as we go along in the photos, but I urge you to see if you can see them in the photos yourself, because whenever you get done this webinar series, the next time you're in practice, the question is, can you use these skills? That's the important part. So if we put shift together with tilt, I think it's worthwhile stopping here for a minute, because the pelvis is so much the center of human architecture that if you combine shift and tilt, you get to 4 pelvic types. Now, we're not talking about left tilt or right tilt of the pelvis, that would, or a left shift or the right shift of the pelvis. That's going to come in when we start to think about gait, because you can't do gait without some left-right tilt of the pelvis. Or some people, if you go to New Orleans, they're going to accomplish that with a left-right shift. But the what I'm thinking about here is more anterior, posterior. And I just want to make sure, because I'm going to use this language further on down the webinar series, that you understand what I'm talking about. When we talk about a pelvic shift, we're talking about what happens to the hip joint and the pelvis that goes along with the hip joint. And we're talking about it relative to the feet. So this would be an anterior shift of the pelvis relative to the feet. This would be a posterior shift of the pelvis relative to the feet. In American culture, you see an anterior shift a whole lot more than you see a posterior shift. But we will see as we go along here what's going on with this when we see these kinds of patterns. And you also have an anterior tilt and a posterior tilt. Everybody knows what that is? Yep, anterior tilt, pubic bone goes down. Posterior tilt, the lumbars go flat. You get no rear end, and the sacrum goes into, the whole pelvis goes into posterior tilt. Sacrum goes into counter nutation. So, if we look at this and you put all those together, you get 4 types. If you look at somebody, it's worthwhile typing. I hate typologies actually, but this is worth looking at and then forgetting. So if you look, that will give you 4 types. It could be an anterior shift, anterior tilt. So the anterior shift, if I were to talk about it in detail, the anterior shift, that's my pelvis relative to my feet, means that there's got to be a tilt somewhere in the legs in order for my pelvis to get there. So this would be an anterior tilt of the leg. However, the end result is an anterior shift of the pelvis. Now, anterior shift, anterior tilt, when I say tilt, I don't mean relative to the feet. I mean the tilt, this is just our convention, this is how we do it, that the tilt is relative to the femur. But do you see that the femur is already leaning forward? So this would be a neutral pelvis to the femur. That would be an anterior tilt of the pelvis relative to the femur. And that would be a posterior tilt of the pelvis relative to the femur. There's not very many muscles connecting the pelvis to the ground, unless you read that Myers guy and don't believe him. Most of the muscles that determine the position of the pelvis attach to the femur. So what we really are interested in is the position of, in terms of tilt, is the position of the pelvis relative to the femur. So if the femur is leaning forward and the pelvis is like this, it's not an anterior tilt pelvis. It's neutral relative to the femur. It's not neutral relative to the ground. But there's not much happening relative to the pelvis and the ground. Lots happening between the pelvis and the femur. That's neutral. So, going back to the 4 types again. Anterior shift, anterior tilt. You see it? It does mean a lot of pressure in the low back. Here's the one that you really commonly see and that I think doesn't get recognized enough. Anterior shift, posterior tilt. Lots of folks who are in the yoga and the Pilates world have this kind of pattern because they're ambitious and they're anxious, so they're putting their pelvis forward, but they have been told to tuck their pelvis under, ergo they tuck the pelvis under. If you look at this, it looks like an anterior tilt relative to the floor, but it's a posterior tilt relative to the femur. This is important because if you take this person, this is what happened to me in my Rolfing training, so I've refined this since I had there. If you look at this and you say this is an anterior tilt relative to the floor, and then you say, oh, it's an anterior tilt, I need to work on the pelvic flexors, the hip flexors, you open these up, this is just going to get worse and worse. They're going to tuck their tail under even more. These folks need to be opened in the deep lateral rotators and the hamstrings and the adductor magnus. That's going to allow the pelvis to come back over, and they're actually going to get a little bit more of a tush because when the pelvis is tucked under like that, I don't think that's going to do much with my basketball butt, as my wife calls it, but you can imagine that with somebody else you could get to a posterior tilt. So posterior tilt, anterior shift is something you'll very commonly see among the overexercising of the 21st century American upper middle class folks that we all get to work on, and that population will show you a lot. Anterior shift, posterior tilt. So anterior shift, anterior tilt, anterior shift, posterior tilt. Got 2 more. You could have posterior shift, anterior tilt. If you look, you'll see that this is a pattern favored by 2-year-olds everywhere. You don't see it very often in adults. You do occasionally see it in adults, But a posterior shift, anterior tilt is usually a transitional stage that kids go through as they're learning to walk. Perfectly normal for them, not so normal for an adult. The last one is one that you will see very commonly, especially these days with a lot of computer work, which is posterior shift, posterior tilt. Now, if you notice what happens when I go into a posterior shift, posterior tilt, the lumbars get flat, the bum gets flat, the sacrum gets flat, and that is very commonly what you see. I often call this the plumber's pattern because if you wear blue jeans with this kind of pattern, the blue jeans are going to hang down here and give you a little bit of a vertical smile. But that's just a joke. You can find that pattern in all kinds of people, and we're increasingly finding it among those who are office-bound, who sit in their chairs, go clunk on their chairs so that they're in a posterior tilt all the time, and when they stand up, they end up in this posterior shift, posterior tilt. So it's worth saying to yourself when you see somebody, anterior shift, anterior tilt, anterior shift, posterior tilt, posterior shift, anterior tilt, posterior shift, posterior tilt. Because that, again, the reason that we're going through this is not to be smarter than the average bear, but because it leads to strategies that we can then use. So, we've been through the terms, we've been through the pelvic types here, just as a way of understanding those terms. Now let's go through the whole 5 stages of what we're going to do.
All right, so now let's take a look at this young man. We're going to call him Forrest because that's his name. And thank him very much for coming in to be a model here. And we're going to have a look at these photographs and put this terminology and this set of ideas into use. So if we look, you can take your first impression from imagining that Forrest is standing in front of you in the class. Again, I don't like to put words on a first impression, but I don't know, the first impression that I have is somebody who's wide open in the chest, very soft feeling, but muscular and sturdy in the legs and not so comfortable in the shoulders. These all might be, by putting words on it, I'm taking away from the first impression, which is just a gestalt of your feelings that this person creates. But I just want to notice it as it goes by. And that elides easily into the 3 positive things. If I look, I see somebody who's young and healthy, very sturdy legs, obviously an outdoor lifestyle, tan, so he's getting enough sun, and he has a very soft and curious demeanor, which I like. And these are all positive things that Forrest brings to our encounter. That said, there are a few things that, if he were coming into my practice, that I would try to engage him in improving. So if you look, and I just want this to be our practice at these 5 stages of body reading. We'll be going in primarily to the first and second stages, and subsequent people we'll be looking at. But if we look at this with Forrest, I say, where is the skeleton in space? So I can have a look, and I can see that compared to his hips, can you see that the shoulders have a right tilt, that the right shoulder is lower than the left, and that his head also has a right tilt, and if you look in between the shoulders and the head, the neck has a right tilt. So the relationship between the shoulders and the head is neutral. But if I look at the relationship between the shoulders and the rib cage, the shoulders are falling to the right of the rib cage. The rib cage is not as tilted as far to the right as the shoulders are, I don't think. Hard to tell looking at photos, but I had the young man here. Now, the second thing you can do with that is look at the space between the arms and the body, and I don't actually like looking at the space between the arms and the body. What we want to look at is the distance from the fold at the armpit down to the top of the hip. And do remember to measure to the top of the hip, not to the top of his bathing suit or underwear, because that can lie to you if the underwear is a little bit tilted, without the pelvis being tilted. So it looks to me, looking at this photograph, as if the distance from his right armpit to his right hip is shorter than the distance from his left armpit to his left hip. And therefore, I might be drawn to the soft tissue of the lateral line, or the lateral abdominal obliques, or the quadratus lumborum, or iliocostalis, or something down in that corner that could be pulling his rib cage over to the right. If we switch now and look at him from the back, which is a really good thing to do because often people make themselves look good in the front and they don't know how to make themselves look just as good in the back, so you can see things from the back that you can't see from the front. And obviously when looking from the back and the front, we're going to have a good way of seeing the differences left and right. So you can see how that right arm hangs down lower than the left, how the right shoulder is farther away from the midline or laterally shifted more than the left. And I think you can see how the left shoulder is also kind of creeping around the body, what we're going to call a medial rotation of the scapula. Remember, we're not talking about a medial rotation of the shoulder joint. We're not talking about a medial rotation of the humerus. In fact, his left humerus looks laterally rotated compared to the right. However, the scapula is trying to crawl around that rib cage to the front, and we're going to call that a medial rotation. So if we were putting this all together, we could say that the rib cage has a right tilt, but now I'm looking at the pelvis from the back and it looks as though the pelvis has more of a right tilt from the back. And then I go down to his knees. Is the right knee a little lower than the left? Kind of looks it from here. And so I'm wondering about whether the right leg is shorter than the left leg, and that could be a functional shortness, most likely, or an anatomical shortness, rather less likely. But you can see he's putting his right leg out a little bit like a kickstand and then leaning onto it with his weight. When I take a history, which I'm deliberately doing this without a history, when I take a history, I'd be interested to know whether he's had any injuries to his left leg or whether it's just the longer left leg is shoving the weight over to the right. Do you see how I'm beginning to build a story out of the pattern that I see? The head is off to the right, the shoulders are off to the right. There are other stories we could tell if we go back to the front line. Do you see if you took a line straight up between his feet, straight up the gravity line, parallel with the outside of the picture, that we would go through his left eye? It could be that he has a very strong, dominant left eye, and that he's putting that left eye on the midline. My whole story about the short right leg and him moving on to or having a problem with the left leg, so he's moving on to the sturdier right leg. Both of those are stories which we could check. But here's a third story. He could be simply locating his dominant eye along his center line and everything else follows from that. I don't know until I do some experiments and I start working with him and I see what kind of response there is. Can you see that the head, now to put this in language again, you can see this in either the front or the back view, the head is right tilted and right shifted relative to the pelvis. If we think of the pelvis as horizontal, well, closer to horizontal than the head certainly, the head is tilted off to the right, but it's also shifted off to the right. So you don't preclude a shift or a rotation just because you're talking, you don't preclude a tilt or a rotation just because you're talking about a shift. It could be shifted and tilted, or it could be shifted with no tilt, or it could be tilted with no shift. However, in Forrest's case, his head relative to his pelvis is tilted to the right and shifted to the right. So if we now look at his right and left sides, we can also see some of the shifts, some of the things that I was talking about earlier. For instance, his pelvis is anteriorly shifted relative to his feet, and yet his shoulders are posteriorly shifted relative to his pelvis, but I believe his shoulders are relatively neutral to his feet. So you kind of get to this thing. It's a very common posture you see. You see this kind of bow shape from the ankles to the shoulders, and then the head is projected forward of that bow shape. Whenever we see a bow in the anatomy trains world, we look for a bowstring. So his superficial back line between his shoulders and his ankles has to be short somewhere along there. That's what's pushing the pelvis forward. And so we'd look to release that, but if that's going to make sense to him, we're also going to have to release the scalenes or something deep in his neck, because you can see the angle between the rib cage and the neck in either one of these, the left or the right. The rib cage is leaning back and the neck is leaning forward. For him to get an easy, upright, erect posture where he can really fully use his breathing, where he's living his full length, will involve bringing the pelvis back over the feet, and at the same time will involve opening up the front of his neck so that his head can sit on top of his rib cage, can sit on top of his pelvis. He leans back with the rib cage so that his head is over his pelvis, leaning back with his rib cage, his shoulders are over his feet, but the head over the pelvis and the shoulder over the feet, those are lined up, but the head and the pelvis are not lined up with the shoulders and the feet. So to help get him lined up, which means that the weight would be taken down through the bones, which would mean that he was using the minimum amount of muscle activity and therefore the minimum amount of metal activity and therefore the minimal amount of sugar and from his blood would be if he were lined up. It would also reduce what's known in physics as his moment of inertia. If you want to know about moment of inertia, think about a skater. A skater starts with their arms out, spinning slowly, and then when they bring in their arms, they lower their moment of inertia and they turn into a blur. And when they come out again, they put the arms out. So for everything that you see that is shifted back and forward, he's losing energy to having not a minimum moment of inertia. So don't mean to go all geeky on you, but this, the idea of having an aligned posture makes you very ready to move in any direction. Forrest, bless him, is not absolutely ready to move in any direction because he's leaning back in his rib cage and he has to move before he can move. He's not ready to move. He's not poised at the acme of his posture. He has settled down into it. We would love to release some of the tension down in his lower back, at the lower part of the ribs. We'd absolutely love to release the tension in the front of his neck. I'm now talking strategy. And we'd like to go up the front of the legs and down the back of the legs in order to help him. I wanted to just do one more thing here, which is you don't get these kinds of bends and tilts that we were talking about without rotations happening also. So if we look at this picture where we look down at Forrest from above, of course it's a very foreshortened view of his body that makes his shoulders look very big and his feet look very small. But if you drew a line across the back of his underwear, we'll be more formal about that when we get to this, but if you drew a line across the dimples at his PSIS, the little dimples just above his pelvis, do you see how that line would be going forward on the right side and backward on the left side? If we now drew a line that joined the two ends of his scapulae, do you see how that line would be going down on the right side and up on the left side? In other words, his rib cage is not headed in the same direction of his pelvis. He has a right rotation of his rib cage relative to the pelvis, and then he has a left rotation of his pelvis relative to his feet. So just as with the shifts, you can't just take the rotation out of the pelvis and expect it to go both ways. You're going to need to relieve and ease tissue in such a way that the rotation between the pelvis and the feet disappears, and the rotation between the pelvis and the rib cage or the shoulders disappear also. It is this kind of strategy and this kind of seeing that we're going to be working with throughout the rest of the series.